Hello and welcome to HSE Antibiotic Prescription Aligned series. Today, we are talking about conjunctivitis. The content of this video is for educational purposes. Your treatment decisions are your own responsibility.
You know, it's that Monday morning reflex, right? You wake up, or maybe you get that dreaded call from the school, and there it is.
Red sticky eye.
Exactly. And the immediate thought, our conditioned response, is to just rush to the pharmacy, get some drops, and, fix it.
We treat it like an emergency that needs an immediate antibiotic.
Yeah.
But if you actually look at the current HSE guidelines, that whole reflex is, well, it's not just outdated. It's part of a much bigger problem.
Of a public health problem.
A huge one. It's a classic case of medical culture lagging behind the science. We've just always equated pink eye with bacterial infection, so unlearning that takes a real conscious effort.
So for this deep dive, we're looking at the HSE guidelines on antibiotic prescribing for conjunctivitis. And the main idea here is, surprisingly, about restraint.
It is. It's less about what medication should I take and much more about, hang on, should we be treating this at all?
Which I imagine is a tough sell when you're facing a parent who's anxious and just needs to get their kid back to daycare so they can go to work.
Of course. But the document is really pushing for this idea of, well, they call it delayed prescribing. Before we get into that, though, we have to talk about the diagnosis.
It's detective work.
The detective work. The guidelines make a really clear distinction between viral and bacterial causes, which I think gets lost in a quick 10-minute GP visit.
Right, and that's where things go wrong from the start.
It is. The guidelines are pretty clear that the vast majority of these cases are viral. So if we're handing out antibiotics for 80% of red eyes, but 80% of them are caused by a virus,
You're just throwing medication at a problem it can't solve.
you're pouring it down the drain. Or worse, you're actually fueling antimicrobial resistance.
Okay, so let's get into the clues. How do you or a doctor tell the difference? The guidelines list some specific things to look for.
They do. So for a viral case, you're often looking at, say, older children over 5, and it's more common in the summer. But the real key is the discharge.
Watery versus sticky.
Exactly. With a virus, like an adenovirus, the eye is irritated, so your tear glands just go into overdrive trying to flush it out, hence watery.
And with bacteria.
That's different. Your immune system sends in the troops, the white blood cells, and they fight the bacteria and die. That pile of dead cells is, well, it's pus.
The classic mucopurulent discharge they talk about.
That's the one. So the glued eye in the morning is a huge bacterial hallmark.
So if you wake up and your eye isn't sealed shut, it's just a bit gritty and red.
The probability of it being bacterial just drops significantly. Also, with viral cases, you often get other symptoms like light sensitivity photophobia, or, you might have a bit of a cold or a sore throat. It's rarely just the eye.
Okay, but here's the twist. Let's say I do have the glued eye. It's just one eye. It's got that yellow-white discharge. It ticks all the bacterial boxes. The guidelines still say that jumping to antibiotics might be the wrong move.
Yes. And this is the core of it. It's because of the natural history of the disease.
It just gets better on its own.
For the most part, yeah. The data shows that acute bacterial conjunctivitis is very often self-limiting. Your immune system is usually more than capable of clearing it up.
So symptoms resolve in about 5 to 7 days, is that right?
That's what the data suggests, and that's whether you use antibiotic drops or, say, a placebo.
So the drops might shave, half a day off the symptoms, maybe?
Marginally, yes, at best. But that comes at a cost, and not just the price of the bottle. This gets us to the why behind this whole delayed prescribing strategy.
It's all about resistance. I think people get the idea of superbugs in an abstract sense. But for eye drops, is the risk really that big?
It's actually a perfect breeding ground. When you put an antibiotic drop in your eye, it doesn't just stay there. It drains down your tear duct into your nose, into your throat.
So it's exposing all the other bacteria in your system to the drug.
All the good bystander bacteria living on your skin and in your respiratory tract. You're giving them a small dose. Not enough to kill them, but just enough to teach them how to survive it.
You're basically training them to be resistant.
You are. So the next time you get a real infection, something serious, those resistant genes are already out there. And that's why the HSE is pushing this delayed prescribing idea so hard.
Okay, so walk me through that. The doctor thinks it might be bacterial. They write the script for chloramphenicol, but then they tell you.
They tell you to wait. It's the 3-day rule. You leave with the prescription in your hand, which is, a psychological comfort.
Or a safety net.
A safety net. But the advice is to use self-care measures first. Clean the eye, wash your hands, and wait. If it isn't getting better by day 4, Then you go fill the script.
And that self-care is pretty important. It's not just do nothing.
No, it's about strict hygiene. Washing hands with soap and water or an alcohol rub. And one really practical thing they highlight is how you apply the drops. People often touch the tip of the bottle to their eyelid.
Oh, contaminating the whole bottle.
Exactly. So you're treating the eye with one drop and then reinfecting it with the next. The protocol is very clear. No touch application.
You know, there's another angle here. Schools and daycares, I feel like the old exclusion policies were a huge driver for antibiotic demand.
They were a massive driver. Parents needed the drops to get the note, to get their kid back in so they could get back to work. It was a perverse incentive.
So what's the new advice?
The public health advice now is explicit. Kids do not need to be kept out of school or childcare if they're otherwise well.
That's a game changer. It basically reframes pink eye as being more like a common cold than some sort of biohazard.
Precisely. Unless there's, a major outbreak or the child actually has a fever and feels unwell, the red eye alone is not a reason to send them home. That takes so much pressure off the parents and the doctors.
All right, so let's say the 3 days are up, the eye is no better. We're going to use the drops. The first choice is chloramphenicol. But there are some really big safety warnings here that I don't think many people know about.
There are. Chloramphenicol is a great antibiotic, a real workhorse, but it has a specific toxicity profile. The biggest red flag in the guidelines is for pregnancy and breastfeeding. It's just not recommended.
Okay, so that's a clear line. But then there's this really interesting and complicated story about its use in kids under 2. It involves boron.
The boron controversy, yes. This is fascinating. For a period starting around April 2021, there was a hard stop on using these drops in infants.
And it wasn't the antibiotic itself, it was something else in the bottle.
It was an excipient, an inactive ingredient. The drops contain borax or boric acid boron to act as a pH buffer so it doesn't sting your eye.
And boron was suddenly considered a risk.
Well, some animal studies had linked very high levels of boron to potential reproductive toxicity later in life. Based on that data, European guidelines shifted, and suddenly this standard first-line treatment was off the table for toddlers.
But then it came back. The guidelines mention an update in August 2022, where the HPRA, the Irish regulator, reversed the decision.
They did. They did a much more detailed risk assessment. They looked at the tiny surface area of an infant's eye and calculated the maximum possible amount of boron that could be absorbed.
And compared it to what we get normally.
Exactly. They compared it to the background level of boron we all get from food and water. They concluded the exposure from the eye drops was tiny, well below any level that could cause a toxic effect.
So the benefit of treating the infection was way higher than the theoretical risk.
Precisely. The restriction was lifted. But it's a great example of how these safety guidelines are always evolving with the data.
It really is. Okay, so if chloramphenicol is out, say, for a pregnant patient, the alternative listed is fusidic acid.
Right, which is a viscous drop, more like a gel. It's often easier for people because the dosing is only twice a day instead of every few hours.
But it's a totally different kind of drug.
It is. And this is where the microbiology really matters. Fusidic acid is fantastic against gram-positive bacteria, like Staph aureus, which is a really common cause, but it has a huge blind spot.
What's that?
It has almost no activity against gram-negative bacteria.
Okay, so why does that distinction matter so much for what seems like a simple eye infection?
Well, for a standard case, it might not. But if your patient wears contact lenses, the whole game changes.
Ah, because they can get different bugs?
You get much nastier bugs. Contact lens wearers are at risk for infections from things like Pseudomonas aeruginosa.
Which is gram-negative.
Correct.
Right.
And Pseudomonas is not something you mess around with. It can cause what we call a corneal melt. It can literally destroy the cornea. So if you give fusidic acid to a contact lens wearer with a Pseudomonas infection,
You're using a useless weapon.
you're using a drug that Pseudomonas just shrugs off while the infection gets worse and worse. The patient thinks they're being treated, but the damage is still happening.
Wow. Okay, that's a perfect lead-in to the red flags, because the whole point of being patient with the minor stuff is so we don't miss the really dangerous stuff. And contact lenses are clearly red flag number 1.
Absolutely. The threshold for referring a contact lens wearer should be incredibly low. You have to worry about microbial keratitis, an infection of the cornea itself. If there's real pain, or if you can actually see a little white spot on the clear part of the eye, that is a medical emergency.
Then there's the other end of the spectrum, the hyperacute cases. You're talking about an infection that develops in hours, not days.
This is the nightmare scenario, hyperacute conjunctivitis. The eye is just pouring thick green-yellow pus, happens incredibly fast, within 12 to 24 hours.
And the main suspect there is?
Neisseria gonorrhea. Gonorrhea. People think of it as an STI, but gonococcal conjunctivitis is devastating. It can actually penetrate an intact, healthy cornea.
It can eat right through the surface of the eye.
Yes. And it can cause perforation and blindness very, very quickly. This isn't a try some drops situation. This is an immediate referral for systemic injectable antibiotics. It can affect anyone, newborns, teens, adults.
So if it's super fast and super gross, it's an emergency. What about the opposite, the slow burn chronic infections?
Right. So if a patient comes in and says they've had a mildly sticky, irritated eye for more than 2 weeks, maybe even a month, you have to think about chlamydia trachomatis.
Another STI.
Exactly. It presents very differently in the eye. It's low-grade, chronic, persistent irritation. And just like with gonorrhea, topical drops alone will not cure it. You need oral antibiotics to clear the infection from the whole body.
This all just reinforces how flawed the just give me the drops reflex is. If it's viral, they're useless. If it's chlamydia or gonorrhea, they're useless, and you're missing the real problem.
And if it's a contact lens keratitis, the wrong drops could lead to blindness. The paradox is that the one type of infection that's safe to treat with standard drops is actually the one that needs treatment the least.
So the goal of the doctor's visit isn't to get a script. It's to rule out the really bad actors.
That's it, exactly. And the guidelines list other triggers for referral. Severe pain is a big one. Any decrease in your vision. If you can't read the letters on a chart as well as you could yesterday, that's not simple conjunctivitis.
And they also say if you do use the drops after the 3-day wait and there's no improvement after another 2 days,
You stop. You reevaluate. Because it's probably not a typical bacterial case. It could still be viral or something else entirely.
So to pull this all together, what the HSE is asking for is a big shift. They're asking doctors and patients to tolerate a little bit of discomfort for the greater good of antibiotic stewardship.
Yes. While at the same time being hypervigilant for the dangerous outliers, it's a move away from prescribe just in case medicine to truly evidence-based practice.
But that needs everyone to be on board. The patient has to understand that leaving the pharmacy empty-handed isn't a failure. It's actually a sign of good modern care.
And that's where the delayed prescription is so clever. It's a communication tool. It validates the patient's concern. Yes, this is an infection, here's the plan. But it empowers them to be the gatekeeper of that antibiotic.
It makes you an active participant.
It does. And it helps break that automatic link between seeing a doctor and getting an antibiotic. If we can do that for pink eye, maybe we can do it for all the other self-limiting things that are driving resistance.
A tiny bottle of eye drops is a microcosm for one of the biggest fights in public health.
It really is. And the final thought I'd leave you with is this. We have these incredibly powerful tools, these antibiotics. But using them for a self-limiting sticky eye might mean they won't work when we really need them for something truly dangerous, like that gonococcal infection.
Yeah.
It's about respecting the medicine.
A powerful way to frame it. So for everyone listening, the takeaway is wake up with a sticky eye. First, check the symptoms, watery or sticky. Second, don't panic. Your body can probably handle it. Third, if you see a doctor, expect that 3-day wait. It's strategy, not neglect.
And fourth, know the red flags. Contact lenses, severe pain, vision loss, or that hyper-rapid onset. Don't wait on those.
And for goodness sakes, wash your hands
Properly. And don't touch the bottle tip to your eye.
Simple advice, but it's the most important. This has been a really insightful look at how a simple guideline can tell us so much. Thanks for breaking it all down.
My pleasure.
And thank you for joining us for this deep dive. Stay curious, stay skeptical, and we will catch you on the next one.
If you like this content, subscribe to the channel and hit the like button for more.